Welcome to the Radiology Vault, an open repository for radiology educational content designed for learners and medical professionals. Presented by the Michigan Medicine Department of Radiology.
Hi, I'm Kim Shampain, and today we're going to review the imaging of renal transplants with particular attention to vascular emergencies. I have no disclosures. To understand complications of renal transplants, we first have to understand their anatomy. The renal transplant is typically placed in an extraperitoneal location in the iliac fossa. The donor main renal artery can be anastomosed in one of two ways, either end-to-end to the recipient internal iliac artery or end-to-side to the recipient external iliac artery, the latter of which is demonstrated in the figure on screen right. The donor main renal vein is typically anastomosed in an end-to-end fashion to the recipient external iliac vein. The collecting system anastomosis is typically performed by making a myotomy in the anterior or lateral bladder wall and directly suturing the transplant ureter to the wall mucosa. What happens if the donor kidney has multiple small accessory renal arteries? These are either anastomosed individually to the recipient iliac artery, resulting in multiple iliac anastomoses, or they are anastomosed to a larger donor renal artery, with that larger artery then anastomosed to the external or internal iliac artery, resulting in a single iliac anastomosis. What happens if the donor kidney has a duplicated collecting system? This is managed in a similar fashion to accessory renal arteries. Either each ureter is anastomosed separately to the recipient bladder, resulting in multiple bladder anastomoses, or the ureters are anastomosed together and sutured as a single ureter to the bladder, resulting in a single bladder anastomosis. On Doppler ultrasound, the normal transplant renal artery waveform should demonstrate a rapid upstroke during systole with continuous forward movement, and the waveform should be low resistance. The normal peak systolic velocity, or PSV, in a transplant renal artery is less than 180 centimeters per second. The resistive index, or peak systolic velocity minus end diastolic velocity, all divided by the peak systolic velocity, should be less than 0.7. On screen right, we see an example of this normal waveform, with the rapid upstroke during systole, low resistance, and continuous forward movement. The calculated resistive index of this example is 0.61. Transplant renal artery stenosis, or TRAS, typically occurs in the 3 months to 2 years following a renal transplant. It is more common with internal iliac artery to renal artery anastomoses, which are the end-to-end anastomoses. The most sensitive and specific findings in TRAS is a peak systolic velocity greater than or equal to 200 to 300 centimeters per second. Other findings include acceleration time greater than or equal to 0.08 to 0.1 second, and ratio of peak systolic velocity in the main renal artery to peak systolic velocity in the external iliac artery greater than 1.8. As we know, these are all ultrasound findings. On CT or MR, TRAS can be seen as luminal narrowing greater than 50%. Here we see a left lower quadrant renal transplant on which color Doppler and spectral analysis were performed. The main transplant renal artery and vein are patent. Notably, there is aliasing artifact and high velocity greater than 250 centimeters per second in the region of the arterial anastomosis, which may reflect an underlying stenosis. Transplant renal artery thrombosis is typically seen in the immediate postoperative setting. However, it can present at any time. On ultrasound, there will be no discernible flow in the renal artery and in intrarenal arcuate arteries. Similarly, transplant renal vein thrombosis is also seen in the immediate postoperative setting, but can occur remotely as well. When this happens, it is often due to rejection. On ultrasound, you'll see no flow in the main renal vein, the diagnostic finding. You'll also see reversal of diastolic flow in the transplant main renal artery with very high resistance waveform. But note that the renal artery findings just described are not specific and can also be seen in the setting of collecting system dilation and rejection. Here we see a spectral Doppler evaluation of a right lower quadrant renal transplant main renal artery. The vessel is patent, but demonstrates a high resistive flow pattern with reverse diastolic flow. This raises our suspicion for renal vein thrombosis. Despite multiple attempts, no venous flow to indicate a patent main renal vein was visualized, either within the renal hilum or renal parenchyma. We are only seeing the arterial signal. This finding confirms our suspicion of renal vein thrombosis. Transplant renal artery pseudoaneurysms are typically formed secondary to biopsy. On ultrasound, a cystic structure in the parenchyma is seen on grayscale imaging. When this is imaged with spectral Doppler, a to and fro pattern is seen, meaning flow is seen both above and below the baseline due to blood entering and then leaving the pseudoaneurysm. On color Doppler, this is seen as a yin-yang sign. On this grayscale image, we see what looks like a 1.5 cm simple cyst in this left lower quadrant renal transplant. However, spectral Doppler of this structure demonstrates to and fro flow both above and below the baseline, with color Doppler demonstrating the swirling yin-yang sign, confirming that this is in fact a pseudoaneurysm. This is a different patient, a 4-year-old with a right lower quadrant renal transplant who underwent recent biopsy, on whom a CT is performed. We see a hyperdense ovoid focus in the renal transplant, which follows blood pool in the parenchyma, consistent with a pseudoaneurysm. So, a few key things to remember. Understanding the normal renal transplant anatomy is key in determining if there is an abnormality. The most sensitive and specific finding in transplant renal artery stenosis is PSV greater than or equal to 200 to 300 centimeters per second. In renal artery thrombosis, there will be no flow in the renal artery on ultrasound. Similarly, in renal vein thrombosis, there will be no flow in the renal vein on ultrasound. You must evaluate any cystic structure in a renal transplant with color and spectral Doppler, as it could be a pseudoaneurysm. These are my references. Thank you.